Good afternoon. I was given an assignment on multi-drug resistant organisms and extended spectrum beta-lactamases among bacterial isolates in the Philippines. So the following are the lecture objectives. One is to give an overview of the antimicrobial resistance surveillance program of the Department of Health, mainly because the data largely presented here come from the surveillance program. Second, to provide updated information on the epidemiology of MDROs, or multi-drug resistant organisms, and extended spectrum beta-lactamases, or ESBL producers, among selected bacterial pathogens based on data of the ARSP of the Department of Health. So I will concentrate the presentation on the following organisms for ESBL. This will be on E. coli, and for the MDROs, on urinary E. coli, Acinetobacter species, Pseudomonas aeruginosa, and Staphylococcus aureus. And last lecture objective is to provide treatment options for the management of ESBL-producing bacteria and MDROs. So the Antimicrobial Resistance Surveillance Program of the Department of Health was established in 1988 with the creation of the Antimicrobial Resistance Surveillance Committee. And this was to have a rational basis for the selection of antimicrobial agents by having up-to-date information on the susceptibility of the more important bacteria to these agents. So ladies and gentlemen, this year, the surveillance program is celebrating its silver anniversary, or 25th year. The laboratory-based surveillance setup is as follows. The origin of isolates come from 22 bacteriology labs housed in tertiary care hospitals, mostly under the DOH, in 14 regions nationwide, which are the sentinel sites. The source of isolates come from clinical specimens of patients, and the methods of isolate collection and reporting are all isolates undergoing aerobic culture and susceptibility. The method of isolate identification follow a standardized protocol, and the susceptibility method is based on the CLSI, or the Clinical Laboratory Standards Institute. There is an external quality assessment scheme and on-site visits to monitor the quality of the data. There are summary reports on an annual basis utilizing a WHO software called WHONET. And as of 2011, 90% of all our culture and susceptibility data are computerized, and this totals to about 31,698 isolates. The limitation of the surveillance is that this data come mainly from hospitals. The types of data generated by the bacteriology labs are demographic data, the identity of the bacterial pathogen, the susceptibility pattern of the bacteria, and for some isolates, the bacterial subtype, serotype, or molecular subtype. So these are just pictures of the different sentinel sites. There are 8 in the National Capital Region, 6 sites in the rest of Luzon, 4 sites in the Visayas, and 4 sites in Mindanao, so a total of 22. The data from the surveillance program have been used in many clinical practice guidelines, such as the urinary tract infection guidelines of the PSMID, ARI treatment guidelines, and so on and so forth. It is also used as a basis for inclusion of antibiotics in the Philippine National Drug Formulary of the Department of Health. As we know, only antibiotics included in this formulary can be purchased by government hospitals. So we go to the second objective, which is on extended spectrum beta-lactamase producing bacteria. And as I mentioned earlier, the data presented will focus mainly on E. coli. This is a representation of the number of urinary pathogens in the surveillance program from 2007 to 2011. And the red-colored bars represent the proportion of isolates which are E. coli. So as is clearly seen from the distribution of the bar graphs, E. coli constitutes about 50% of all E. coli, of all urinary isolates in the surveillance program. This graph also shows the number of isolates per year. In terms of the three other organisms for which I will discuss, the MDROs. So the green bars represent Acinetobacter for the last 5 years. The pink bars, for the Acinetobacter isolates, there are about 800 to more than 1,500 isolates as of 2011. For Pseudomonas aeruginosa, there have been more than 1,500 isolates to more than 2,000 isolates as of 2011. And for Staph aureus, which is the orange bar, we started at about 1,000 isolates and have now reached more than 1,500 isolates. So ESBLs are mutant plasmid-mediated beta-lactamases that degrade beta-lactam antibiotics. And why are beta-lactam antibiotics important? Because approximately 50% of antibiotics used worldwide are beta-lactams. Therefore, we should take very great interest in resistance to this class of antibiotics. ESBLs hydrolyze all cephalosporins, including third and fourth gen cephalosporins, the penicillins, and aztreonam. Most of the ESBLs cannot hydrolyze cephomycins, which include cefoxitin and cefotetan. They cannot hydrolyze carbapenems and glycyl cyclines, such as tigecycline, which was mentioned by our previous speaker. They are rarely resistant to beta-lactamase inhibitors, such as clavulanic acid, sulbactam, and tazobactam. They are most common in the following organisms, mainly E. coli and Klebsiella, but have been reported in other organisms like Proteus, Enterobacter, Citrobacter, Providentia, Morganella, Shigella, Serratia, and Pseudomonas. Just to give you a picture, plasmids are double-stranded DNA found in bacterial cells, and they're independent DNA from the chromosomal DNA of bacteria, and they replicate independently. And they are said to harbor a very important survival trait of bacteria, which is antibiotic resistance. So it is clear from this diagram that it is quite easy for the plasmids mediating antibiotic resistance to transfer horizontally from one bacterium to another. In previous years, there were phenotypic methods used for detection of extended spectrum beta-lactamases, such as the double disc method, the combined disc method, and the e-test. However, as of 2010, the CLSI have revised their recommendations for identifying ESBLs by mainly limiting or using as basis the zone diameter breakpoints for deciding whether an isolate is an ESBL producer or not. Thus, we no longer need to do phenotypic testing for ESBL in the laboratory, but only for patient management purposes, but we can only perform them if we have interest in performing epidemiologic or infection control purposes. So the latest breakpoints based on CLSI is for ceftazidime in Enterobacteriaceae, resistance is defined as a zone diameter of less than or equal to 17 millimeters. For cefotaxime, it's less than or equal to 22 millimeters. And for ceftriaxone, it's less than or equal to 19 millimeters. And the laboratory can immediately report the isolate as an ESBL producing isolate. With respect to automated systems, there are limitations in automated systems in detecting emerging resistance in gram-negative bacilli. Automated systems are unable to detect ESBLs in organisms other than E. coli and Klebsiella. So we better be aware of this. Now, this graph shows the percentage of ESBL producing E. coli from urine specimens in the Antimicrobial Resistance Surveillance Program from 2007 up to 2011. We can see that in 2007, the ESBL rate was 1.66 or close to 2%. However, as of 2011, it had risen to about 11%. And I have reason to believe that this would rise further in 2012. What about treatment of ESBL-producing bacterial infections? As I said, beta-lactam, beta-lactamase inhibitor combinations are good treatment options. However, some organisms possess multiple beta-lactamases, especially among gram-negative bacteria. And for this particular isolates, carbapenems are the treatments of choice. If the bacteria produces carbapenemases in addition to ESBLs, The currently recommended alternatives are colistin or fosfomycin or timoxylin or tigecycline, either as monotherapy or in combination. Unfortunately, the experience in the use of these antibiotics in the pediatric age group is very minimal. The antibiotic with most experience in the pediatric age group is perhaps colistin. There is need for periodic in vitro testing since resistance may arise at any time during therapy. There need to be strategies to combat multi-drug resistant gram-negative infections, and among these will be empiric combination therapy, meaning use of more than one antibiotic for empiric treatment. Second is pharmacodynamic optimization of dosing regimens, which I will explain shortly, limiting antibiotic exposure among patients, and active surveillance combined with infection control, which we all are aware of. So this table just shows the ways by which pharmacodynamic optimization of dosing regimens can be achieved. And we do this by maximizing killing activity to counteract or prevent antimicrobial resistance. So based on the pharmacodynamic properties of antibiotics, there are corresponding goals of therapy on which dosing is based. For example, for type 1 antibiotics, which are concentration dependent, which exhibit concentration-dependent killing and prolonged persistent effects, as seen in aminoglycosides, daptomycin, fluoroquinolones, and ketolides, we need to maximize concentrations of these antibiotics. For other groups of antibiotics, which are time-dependent killing and have minimal persistent effects, as seen in carbapenems, cephalosporins, erythromycin, linezolid, and penicillins, we need to maximize duration of exposure. And according to the previous speaker, we can even resort to continuous infusion to maximize this duration. For type 3 antibiotics with persistent effects, time-dependent killing, and moderate to prolonged persistent effects, such as in azithromycin, clindamycin, oxazolidinones, tetracycline, vancomycin, we can maximize the amount of the drug. There are certain beta-lactam, beta-lactamase inhibitor combinations in late clinical development versus ESBL-producing gram-negative pathogens. These include avibactam with ceftazidime or ceftaroline, and tazobactam with ceftolozane, just for info. Now we proceed to MDROs. I still have 18 minutes, so I can do this fast. What is the significance of MDROs? The emergence of MDROs are important public health problems due to the limited treatment options available to clinicians like us. The phenomenon has been seen in gram-positive and gram-negative bacteria, and we have seen this in our clinical practice. MDR is defined as acquired non-susceptibility to at least one agent in 3 or more antimicrobial categories. In recent years, there had been many reports or studies on MDROs, and there has been confusion as to what antimicrobial categories need to be compared to be able to arrive at a conclusion that such pathogens are MDROs. So a group of experts published in Clinical Microbiology and Infectious Diseases in 2012 the important antimicrobial categories which were considered to be epidemiologically significant categories for common microorganisms causing healthcare-associated infections, and were usually can be used as basis for classifying organisms as MDRO or not. For instance, for Enterobacteriaceae, these were the antimicrobial categories identified. So we have aminoglycosides, anti-MRSA cephalosporins, which includes ceftaroline, anti-pseudomonal penicillins with beta-lactamase inhibitors such as ticarclav and piptazo, carbapenems, non-extended spectrum cephalosporins, which includes first and second generation cephalosporins, the extended spectrum cephalosporins, such as the third and fourth generation cephalosporins, the cephomycins, such as cefoxetine and cefotetan, the fluoroquinolones, the folate pathway inhibitors, the glycyl cyclines, such as tigecycline, the monobactams, such as astrinam, the penicillins and beta-lactamase inhibitors, the phenicols, the phosphonic acids, polymyxins, and tetracyclines. So there are many antibiotic categories which can be used as basis for categorizing Enterobacteriaceae as MDROs. So there also have been categories for Staph aureus, Pseudomonas aeruginosa, and Acinetobacter, as well as Enterococci. And I will not go into the details of this anymore. So what are the proportions of MDR among our E. coli urinary pathogens from 2007 to 2011? As I mentioned earlier, again, this is resistance to at least one antibiotic in an antibiotic category. Okay? So in 2007, the MDRO rate was about 38%, but this had risen to almost 70% in 2011. And you can see that there has been a gradual increase in the proportion of isolates which were MDRO. And this table shows the number, the most frequent antibiotic classes for which the isolates were MDRO. And out of 1,090 E. coli urinary isolates, 20%, close to 21% of these had a 3 antibiotic category MDRO resistance. And there have been isolates which have resistance to at most 14 antibiotic categories. And the most common antimicrobial combination exhibiting MDROs among urinary E. coli isolates were those under first or second generation cephalosporins, those with concomitant folate resistance as well, and those with penicillin resistance as well. The second most common antibiotic combination for MDRO is a 4-drug combination, which includes resistance to a penicillin plus a beta-lactamase inhibitor, resistance to a first and second generation cephalosporin, folate pathway inhibitor, and resistance to penicillin. Now we go to MDROs for Acinetobacter. As you know, Acinetobacter is a very antibiotic-resistant organism, and we have seen reports of this in many countries. So in our country, in 2007, the MDRO rate among our Acinetobacters was about 54%, and this has remained almost the same at about 51% in 2011. And you will not be surprised to find out that the most common number of antibiotic classes for which there is resistance is already at 7 antibiotic classes, which constitutes almost 6% of all the isolates in 2011. And these are the antibiotic combinations in the 7 antibiotic class resistance: aminoglycosides, beta-lactamase plus inhibitors, carbapenems, extended spectrum cephalosporins, folate pathway inhibitors, fluoroquinolones, and tetracyclines. For Pseudomonas, the problem is not as bad as Acinetobacter, but nevertheless bad as well. So it's about 30% in 2007 and has gone a bit lower in 2011 to about 24%. And the number of antibiotic classes for which isolates for MDRO were 6 classes, constituting 2.2% of the isolates in 2011. And these were the antibiotic combinations: aminoglycosides, beta-lactamase plus inhibitor, carbapenems, anti-pseudomonal cephalosporins, fluoroquinolones, and monobactams. For Staph aureus, the MDRO rate is still lower than Pseudomonas, but still worrisome. In 2007, it was about 15% and has remained to be almost the same until 2011. And the most common number of antibiotic categories for which the isolates are resistant is 3 out of 1,749 isolates, representing about 2% of the total. And these are resistance to cefamycin, folate pathway inhibitors, and penicillinase-sensitive penicillins. So, in the last few slides, I will give you some general recommendations for routine prevention and control of MDROs, as recommended by the U.S. Centers for Disease Control. Basically, these are under 6 categories. One is administrative measures and adherence monitoring. Second is MDRO education. Third is judicious antimicrobial use. Fourth is surveillance. 5 is infection control precautions to prevent transmission. And 6 is environmental measures. Needless to say, there is need for combined tiered approach because more often than not, more than one preventive measure is needed to control, if not eradicate, MDROs in the hospital setting. So under administrative measures and adherence monitoring, we need to make MDRO prevention and control an organizational priority. We need to provide administrative support and both fiscal and human resources to prevent and control MDRO transmission. This is actually easier said than done. Among us infection control practitioners, it is very difficult to ask for resources from hospital management to implement measures to prevent and control MDROs in the hospital. And I'm sure several of you have experience on this. There is need to identify experts for analyzing epidemiologic data, recognizing MDRO problems, and devising effective control strategies. In our hospitals, have we ever looked at whether there are MDRO problems in our hospital setting? Have we ever tried to monitor whether these MDRO rates are increasing or decreasing? If not, then probably it's about time, considering that in the national data, the rates are already very high. And we may never know that it may be worse in our own hospitals. We need to implement multidisciplinary processes to monitor and improve healthcare professional adherence to recommended practices for standard and contact precautions, foremost of which is strict hand washing. We need to implement systems to designate patients known to be colonized or infected with targeted MDROs, and to notify receiving healthcare facilities or personnel prior to transfer of such patients within or between facilities. I don't know how well this is observed locally. We are used to transferring patients, but maybe we fail to notify receiving hospitals whether the patient we are transferring is a carrier of multi-drug resistant organisms, thereby making the receiving hospital a target for receiving such drug-resistant pathogens among their patients. There is need to provide updated feedback at least annually to healthcare providers and administrators on facility and patient care unit MDRO infections, changes in the prevalence in the incidence, problem assessment, and performance improvement plans. So this is responsibility of ID specialists. Do we ever provide feedback to our hospital administrators that this problem is existing in our hospitals? If yes, what are our proposed solutions? MDRO education, provide education and training on risks and prevention of MDRO transmission during orientation and periodic educational updates for healthcare personnel. Do we conduct educational training to all staff of hospitals? Do we conduct infection control training programs for all new employees of the hospital? Yes or no? Walang sumagot. Maybe some yes, maybe some no. But maybe we should do it. It's our responsibility. Third is judicious antimicrobial use. In hospitals and long-term care facilities, ensure that a multidisciplinary process is in place to review local susceptibility patterns or antibiograms and antimicrobial agents included in the formulary to foster appropriate antimicrobial use. Do we ever review the susceptibility patterns of our hospital? Or before that, do we even prepare antibiograms of our hospital on a regular basis? Next, implement systems to prompt clinicians to use the appropriate agent and regimen for the given clinical situation. This may be pharmacy unit director notification or clinician notification. This is actually a very sensitive issue in the hospital when ID consultants try to advise non-ID consultants that they should use appropriate regimens for appropriate situations. It often results in misunderstanding and misunderstanding. Next is surveillance. Use standardized lab methods and follow published guidelines for determining antimicrobial susceptibilities of targeted and emerging MDROs. I think that's quite simple. We need to improve our laboratory methods, monitor trends of incidence of target MDROs over time to find out if the rates are increasing or decreasing, or if additional interventions are needed. And next is, in hospitals, develop and implement lab protocols for storing isolates of selected MDROs, for molecular typing when needed, to confirm transmission or delineate epidemiology of MDRO in facilities. Now, this is the age of molecular typing, and we need to go beyond this diffusion in tracking our MDROs. So there is need to upgrade the methods in the laboratory. Next, we need to follow standard precautions in all healthcare settings, use contact precautions in patients known to be colonized or infected with target MDROs. Masks are not recommended for routine use to prevent transmission of MDROs, but need to be used when performing special situations, such as splash generating procedures, caring for patients with open tracheostomies, and so on. With respect to patient placement in hospitals, again, this is a contentious issue with hospital management. When single patient rooms are available, assign priority for these rooms to patients with known or suspected MDRO colonization or infection. Give highest priority to those patients who have conditions that may facilitate transmission, such as uncontained secretions or excretions. More often, the hospital administration would tell us it's very expensive to exclusively assign one room for a patient with MDRO. For environmental measures, we need to follow recommended cleaning, disinfection, and sterilization guidelines for maintaining patient care areas and equipment. We need to dedicate non-critical medical items to be used on individual patients known to be infected or colonized with an MDRO. A simple example of this is the stethoscope. Dedicate a specific stethoscope to a person with MDRO. Prioritize room cleaning of patients on contact precautions. Focus on cleaning and disinfecting frequently touched surfaces such as bed rails, bedside commodes, bathroom fixtures, doorknobs, and equipment in immediate vicinity of the patient. So those are some of the more important measures recommended to contain MDROs. So in conclusion, we have seen the emergence of antimicrobial resistant bacteria, especially ESBLs and MDROs, which have become important public health problems in the Philippines and the rest of the world. The successful management and containment of these difficult to treat infections usually require a combination of approaches and strong commitment from all stakeholders. Thank you very much.